This video will discuss the technique and clinical aspects of ultrasound-guided sclerotherapy. Proper use of this procedure is becoming more and more important in the modern practice of phlebology. Ultrasound-guided sclerotherapy plays an important role in the treatment of venous insufficiency that may be associated with minimal large vein surface involvement because it allows for treatment of the underlying source. It is also a valuable adjunct and helps to finish the job after a patient has undergone an ambulatory phlebectomy and/or endovenous ablation procedure. As seen here, a vein will be easily compressible when pushed on with the ultrasound probe, while the artery shown in this film clip is not compressible when pushed with the probe. Sclerotic or successfully treated veins will also appear non-compressible. This video clip shows another example of a partially compressible vein. Partial compressibility is a sign that the vein has an open channel. The next video shows foam filling the channel after it has been successfully accessed and injected. In this last example, a vessel is injected with foam. The foam can be seen to network with the partially open segments distal to the injection site. But if there is significant resistance to flow, stop. Never force the injection. Once the vein has been judged to be completely or partially compressible, the next step is to be lined up. Proper positioning, placement, and handling of the ultrasound probe is very important to successful access and safe injection. Note how the ultrasound image will appear as a stripe all the way across the screen. This is an example of the probe held at an angle. This is incorrect and makes access more difficult. The injection is performed using a 3 cc syringe and a 1.5-inch 25-gauge needle. For larger patients, a 2-inch needle is available. The sclerosing foam is made using the standard syringe-to-syringe technique. Observe the screen for evidence of tissue movement and vein penetration. The screen can and should be used to evaluate the accuracy of the approach to the vessel. This is why it is desirable to access the vein in the middle third of the screen. Of critical importance is to always be certain of intravascular placement. Therefore, never inject without first obtaining a blood aspirate. The use of less aggressive solutions in smaller volumes is especially important when treating partially closed veins that are encountered at follow-up treatment sessions. When performing follow-up treatments on partially closed veins, always make a careful assessment and judgment as to where the medicine might go. In this diagram, the red arrow indicates the injection site. If there is obstruction to flow to the left, the medicine is likely to flow to the right and travel toward the surface. As a result, a very strong medicine will find its way into a very small vein. While there is great variation in protocols, and many phlebologists choose to use ethoxysclerol as their medicine of choice, here is a suggested protocol for primary treatment of the greater saphenous vein using STS. When treating the small saphenous vein, it is rare to need a total of more than 2 cc's of 3% STS foam. The next topics to be discussed deal with trapped blood, also called intravascular hematomas, and how to recognize and manage an injection into the soft tissue. In certain circumstances, a so-called injection aspiration is a useful technique. Here are many important rules to always keep in mind. This clip shows a small collection of foam injected into the tissue. In summary, ultrasound-guided sclerotherapy is a valuable and critical technique for modern phlebology. The technique should not be taken lightly, and rules must be followed. The clinician must use careful thought, planning, and assessment.